Sure. Looks like, yep, that's the right one. Okay, so we had and I'll read it to you and kind of fill in between the lines there. But we had a female client referred to our MAT clinic in Weirton, and she was referred from an MAT clinic in North Carolina, and she was moving to the area from North Carolina. She had prearranged with the clinic to come to ours. They helped her schedule the appointments. We made sure that everything was in place as far as insurance questions and pre-screenings were done. When the client presented, she told us that she was actually prescribed 20 milligrams of Suboxone daily for the past year from the clinic in North Carolina. That the previous clinic had tried to get her down to a lower dose, but they were unsuccessful. She reported experiencing severe cravings and withdrawal. So they ended up pushing her back on the 20 milligrams and had left her there up until the point that she was transferring. She did not tell us that she was at that dose, or nor did they tell us prior to the transfer. When we told her that we typically at our clinic, or always, only prescribe up to a 16 milligram dose of Suboxone, and usually that's what West Virginia Medicaid would pre-approve. She said that wouldn't work for her since she'd tried it before. She became tearful. She was crying and sobbing at the clinic, and she ended up walking out because of it. And she actually went across the river to Ohio to a cash clinic who is known to prescribe higher doses. So my question was, is there anything, first of all, has anyone else come across similar situations and what have they done? Or if they have, is there anything to show that whether or not doses greater than 16 milligram daily are sometimes needed for maintenance doses? Or are those extra milligrams usually just being diverted or wasted? And if you have done it before, did you have any trouble with West Virginia Medicaid authorizing doses greater than 16 milligrams? So I'll throw it out to everyone else.
Awesome. Thank you so much. Any comments, thoughts, questions?
If nobody else is going to speak up about it. So I haven't prescribed over 16 personally, but I know it is definitely a thing. And people legitimately taking higher than 16 milligrams. So the idea of it, like 16 is the most that anybody's brain can be saturated with, is probably true for most people, but that was more when it was coming straight from heroin. With fentanyl, things might be a little different. So I don't know if people's opioid receptors get upregulated or what's going on, but we were talking about it at AAAP conference in December, and there are some people that need 32 milligrams, and they're legit taking 32 milligrams of it. Now we're actually about to do a NIDA study, and this is going to be one of the sites, but we're going to have people on quote unquote low dose Suboxone, which is like 8 to 16, and then high dose. So we're going to have people on like 24 and 32 milligrams. The problem you're going to run into is with insurance, though. So I think it's in the state statutes that you're not supposed to go over 16, which is kind of, the idea is the limit diversion, but it's probably archaic and not necessarily true. So there are probably legit times where people need to be on 20 or more. I mean, you might have to get in a situation, it wouldn't be ideal, but you could possibly write somebody like 16, get Medicaid to cover it, and then additional ones that they could pay for out of pocket. Not ideal, but if it's what keeps people in treatment and they're actually taking it legitimately, which some people do, then it might be reasonable. So that's my spiel on it.
I'll speak up because we just actually did a little research on this ourselves. And from my understanding, like the standard maintenance dose is 16, but West Virginia Medicaid will cover up to 24. Don't take that as correct, though. I'm just giving you what I remember the best from what we were looking at about 2 weeks ago.
That is my understanding of West Virginia Medicaid right now as well, that generally the policy is 16 milligrams. However, they will make an exception for initiation up to 24 milligrams, but only for a 60-day period and only once during a lifetime. So I don't know. I mean, you know, there's always the possibility of getting authorization for special cases, but I agree that probably will be the biggest barrier with that kind of treatment plan.
Yeah, that was the biggest, I think, for us was it wasn't an initiation dose. She had been on it for a long period of time and was still up in there. So we were concerned. Hopefully, you know, if we could have done that differently, maybe we would have, but she ended up walking out. So I guess my question too is what Dr. Husta was saying is, so are the doses up in that range typically for initiation, or is that supposedly for maintenance as far as saturating the opioid receptors?
People can be on a maintenance. I mean, we've seen people that high. I mean, initiation is one thing, but yeah, people can be on maintenance doses that high. You know, just think biochemically. I mean, everybody's brain's a little different. The receptors, metabolism of it, how they're taking it. So somebody could be rapid metabolizers. They might, you know, be taking 16 but getting a lot less in the bloodstream. I think it's like 65% gets cleared regardless of how you take it. So, you know, it's just like with anything. I mean, these are all ranges. So for the average healthy person, probably some college student they studied years ago, 99% saturation at 16. But some people need more probably. But I would say probably if somebody tells you that you have to take 24, you just have to be really careful. Because usually my response is if somebody's taking 24, I say, how much are you actually taking? How much are you selling? Most people are pretty open about that, but some people do need that much. So.
And the other thing I know we've done here is to go ahead and try and engage someone in treatment at the 20 with the understanding is our hope is to bring them down to 16 so they in part so they don't have to pay out of pocket or so we don't have to kind of write whatever we need to write to medicate. And as Tony said, that's sort of limited. They can only be on the higher dose for a limited period of time and once during a lifetime. I didn't know that. So that would they be willing to work with us to try and get them down over a period of time, you know, not immediately drop from 20 to 16 if 20's worked with them for a long time, but to do a slow kind of reduction that they can tolerate. We've done that primarily with pregnant women because we're not going to, you know, if a pregnant woman comes in on 24, we will not drop her to 16 immediately. We will either do that gradually or do that after she delivers.
Okay, so I guess what I'm hearing is that generally we could make exceptions to get people into treatment with the idea that we'll work with them to get them engaged and then try to get them down to that 16 level, and that we think that West Virginia Medicaid will cover that dose without problem. So, all right, thank you.
Well, to clarify, Tony, do you have to do an appeal or you have to do? Yeah. Okay.
Yeah, they'll probably ask for a prior authorization and then to go from there.
Actually,
yeah, I was under the impression that they would just automatically said no, but if there's a chance, then it sounds like it's definitely something worth trying. Thank you.
I had a patient that was on, I had him on a higher dose initial, but it was for initial. I did do a prior authorization with Medicaid and got the higher dose approved. He was a severe opioid addiction. It wasn't too difficult. I mean, they didn't give me a hard time. You know, it was for a limited time, but.
Did you have success getting him lowered to 16?
I did. Yeah, I did.
All right.
Yep. So he went down to 16 milligrams. After about, I'd say we had him on about a month and then started to lower it. So.
Awesome. Any other comments?
I've just been searching since we started and I've been unable to find any West Virginia regulations or statutes that would be opposed to the higher dose for a longer period of time if you were able to overcome the insurance hurdles. They may exist, but they are hard to find.
Yeah, as far as I know, the only thing they say is that you have to be someone who's specialized in addiction if you want the higher doses, but usually they would if you have a pretty decent reason. Other thing we've done is also gene testing here. If patients say that 16 is not working, then we just do gene testing. If they have comorbid depression, that's the only way Medicaid would approve for it, and it would tell you if someone is a rapid metabolizer or not.
Thank you.
Excellent. Was that everything, Jeremy? Did you have any other questions you wanted to ask before we move to the next case?
Yeah, that was everything.
Awesome. That's great. Thank you, everyone. Let's see. So, Jen, I will pull up your case for you and then just turn things over to you.
Okay, thank you. You guys can hear me okay?
Yes.
Okay. This patient is a 38-year-old Caucasian male with Medicaid insurance. And the bottom line question about this is about pain control for people in the MAP program. So this guy has had Crohn's disease for many years, and he says he got into his addiction because of being prescribed opioid pain medication years ago for Crohn's. I'm not sure about that, but that's what he says. And our struggle with him, he's been in the program for about 9 months, almost a year. And he is currently taking 8 milligrams BID. But he recently was hospitalized for his some complications due to his Crohn's disease and had a bowel surgery. His course was fairly complicated. He ended up having a perforation, had to get readmitted. And then after a second surgery, ended up having a wound dehiscence. And when we saw him last week, it was actually the first time we had seen him in 3 or 4 weeks because he had been in the hospital. And one thing we noticed about him was that after his first recent surgery for Crohn's, when he was discharged with a really large amount of what seemed like a large amount. It was oxycodone 10 milligrams, 42 pills that he had used inside of a week, maybe even fewer than 5 days, and also gabapentin, which seemed unusual to me for post-op or for abdominal pain to use gabapentin. The other thing about him is that we know he has divulged to the counselor that he sometimes asks for pain medication, even though he might not need it, so he can have it. We suspect, and I think he may have told this at one point to a counselor, that he sells his medication, or has at times. And so obviously he has had an important reason to have terrible pain and to have good pain control. But now that he's out of the hospital, I'm concerned about what to expect. I did contact the surgical team and just was able to reach them today, as a matter of fact. And the person there, I can't remember if she was a nurse or a case manager, but she told me that since his discharge 2 weeks ago, he had called once for medication, and by one of the surgeons was prescribed 10 oxycodone for pain. And then he called a second time last week and was denied any more opioid medication by the attending who took the call that day, who said that he should be using ibuprofen and Tylenol alternating. They are seeing him again. So he has a wound vac even in, and he says that's going to be in for 3 or 4 months. And so they're going to be following up with him regularly. She said he has an appointment this week, and that I could call after that appointment to see what the surgeon said that day. He's currently living with his mother, and has home health coming in, and also physical therapy, because I guess he's been so debilitated that he's just needing help with walking, standing up straight and walking. We have, since this discharge, we have, it's been 2 weeks almost since he was discharged. I've declined to bring him in for a screen because it was hard for him to even get around his house. He besides Percocet for his current, or besides hydrocodone for his current pain control, since he's been in the program, has had frequent relapses on either opioid pills or gabapentin or benzodiazepines. And when I talked to him last week, he said he had taken a benzo, I think it was Xanax, for anxiety. He has a psychiatrist. He was gonna discuss his anxiety with his psychiatrist. And I saw today that there was a note in there, but I didn't have a chance to review it before today. So I hope that he won't feel the need to reach for benzos again too. Pain control is one question. And then my other question about him is, if somebody, how do you calculate sober days? If somebody has a reason for needing to take an opioid and it was prescribed, they stopped his Suboxone when he was in the hospital, and then they started it as they tapered his oxycodone before he left, he said, and restarted him. And so I wasn't sure how to do that, how to interpret what's sobriety, what's prescribed, but it's appropriately used. So that's kind of a mishmash. I didn't even read this. I'm not sure if there's anything else in here that was helpful. And Amy, our case manager, is on the line. So Amy, if you have anything to add on him, you could jump in.
Thank you so much, Jen. That was great. Amy, did you want to add anything before we jump into any of the recommendations?
I think the only thing maybe is that he did tell the counselor last week that he took that Xanax, and she told him, that he couldn't take it in the program, and he told her he was going to reach out to psych and get a prescription for them so he could have them. And then if you saw a note today, Jennifer, I'm not sure if he did or not. But
yeah, I didn't look at his note today.
Thank you. Does anyone have any thoughts, comments, recommendations for Jen's case?
I just want to say I think that you're doing a great job with a really complicated patient there. That's a tough one. And
Thank you.
And up until that very last part about him threatening to go get a prescription for Xanax, I was going to encourage you to continue working with him. But then all of a sudden I was like, well, I think you should threaten him that if he fills another script for Xanax, that he'll have to go inpatient and get detox from it before you'll accept him back. That's probably what I would do.
Yeah, okay. Yeah, Jen, that's a really complicated case. Okay, so one of the things you asked is where you were not sure why the surgeon started him on gabapentin and opioid as well. So there have been new studies that come out, I think in 2017, and is a treatment of perioperative pain. And so you would find that most general surgeons these days will put a patient on NSAIDs or Tylenol in addition to a narcotic, in addition to gabapentin, and plus and minus clonidine. And that's the regime. We've seen it here as well. And they have some studies that support that. So that's why you would see that. And the thought process behind that is the multimodal approach to pain, with the knowledge that neuropathic pain would likely is a component of this gentleman's pain. Okay, they acknowledge that gabapentin takes months to work for pain, but studies have shown that in the acute perioperative period, it decreases pain if it's added, as well as the anxiety that comes to treating the pain. So we've had a couple of patients actually like him, and because Crohn's disease is pretty prevalent here, and it is a higher incidence in other places. And our approaches to that has been pretty much to talk to the patient to figure out, well, which route are you going to go? So for him, you would need consultation with his general surgeon, as well as a pain clinic, right? Because he is very high risk on the opioid risk tool assessment. And so if he is wanting to go ahead with the Suboxone, then you have to figure out, well, what dose would adequately treat his pain, right? And because he can't take NSAIDs because he has Crohn's. So you're kind of stuck with narcotics and probably gabapentin. And so people like him, actually Medicaid might authorize the 24 or 32 milligrams of the Suboxone, and you'd have to tell him, hey, you have to take it every 2 to 4 hours because the pain treatment only lasts for that long. The other thing we've done for patients like him is to cut his Suboxone down to 8, right? And then you add narcotics on top of that, and the pain doctor will do that, right? And it will be for a certain amount of time, acknowledging that within 2 to 4 weeks, he'll probably go back completely on Suboxone. So you can add narcotics to Suboxone, and you would have the pain relief, but you do have to titrate the Suboxone down to about 8. The recommendation is no more than 16 for someone like him. But really it depends on what he wants, because if he's also doing Xanax and he's also selling his medications, then you'd have to ask him, what do you really want? Because if he's doing that, you really can't treat that. Yeah. So just get his buy-in first, figure out what he wants. If he wants addiction and pain treatment, then you do a multimodal approach. If he doesn't want that and he just wants pain medicine, then for the acute phase, he needs to be referred to a pain clinic. Methadone is also a good option for this gentleman. Yeah, people with chronic pain, methadone, like the treatment dose of methadone is 60 to 120 for narcotic addiction. However, if he has acute pain with it, they'll just divide it in doses, and he would get like 23 times a day. Does that make sense?
Mm-hmm. Yeah, both. Thank you both for the comments and the feedback. He's pretty complicated, and it's complicated because of his physical pain, but also because it's not clear his commitment to the program. Or maybe, I mean, maybe he has a financial reason for, also wanting to sell. So there's a lot of,
all of the above.
A lot of different layers. Great, that gives me a lot to do. Thanks.
And then just to answer the question about how do you count days?
Oh yeah.
In general, what we do is if someone, goes into the hospital, has a procedure, gets prescribed medication, takes it as prescribed, which you don't always know if they're taking it as prescribed, but we do not necessarily have them restart their days. He's a little more complicated than, going in for a single procedure, like a dental procedure or, even a minor surgery and coming out and having, 5 days worth of hydrocodone and then stopping. So he's tough. It does sound like he's taking benzodiazepines not as prescribed and has admitted to that at least.
Yes, and when we discussed that last week, I reset his days, so that sort of made it easy for me. I was like, okay. And when I told him that, he said, okay. He was fine with it. I mean, he knew, that was inappropriate, which it was almost, it's comical sometimes, So, but with the pain medication, I said to him that before I found out about the Xanax, I said, well, you were in the hospital, you got prescribed that, I'm not going to reset your days. And he said, thank you. Right. Then I said anything else. So I was glad that he told me about the Xanax. We weren't screening him, and he didn't have to tell me. Right,
and to me, that's an indicator that there's part of him that really does want treatment for substance use disorder, and it's very difficult when he has both a chronic medical condition, a chronic substance use condition, and pain. Obviously, if he has a wound vac, he's in a lot of pain.
And depression and anxiety.
Yeah.
Yeah.
Wound vacs hurt.
Yeah. It didn't sound fun. And what's interesting is that after the first hospitalization, he was complaining a lot of pain. Well, it turned out he had a perforation, you know, and so you can't always disbelieve people, and you can't always believe people. You have to do both. So,
well, and it's also, when you think about people with a history of substance use disorder going into the hospital and having a procedure and then complaining a lot of pain, they're probably having their pain undertreated. At least I know in some hospitals, we tend not to treat people with opioid use disorder the same way as we treat people without substance use disorders, and the doctors are very leery about prescribing large amounts of opioids when in fact they may need that if they've just had a valve replacement or some kind of surgical intervention, because their tolerance is so high that when you prescribe them the normal dose you would prescribe the normal person for pain, you're not even touching their pain, let alone if they're having withdrawal.
Yeah.
And so I don't know if you guys have, it sounds like your pain team actually did try and treat him, you know, a little bit more aggressively than they would kind of your regular person who doesn't have a substance use disorder.
well, and what Dr. Bose had explained a lot to me about their strategy, so that was helpful. And actually, maybe they, you know, didn't. Yeah, they tried. This case also speaks to our fractured system, because it took me, as you can imagine, an inordinate amount of time to find somebody to talk to about him up from the surgical team. It's just so frustrating, and nobody initiated a call with me. So anyway, that's a whole nother topic that we won't get into today.
No, but that's a pretty important point, Jen. And what we actually had to do here was to tell them, hey, any patient you all have on Suboxone or methadone or chronic opioids, you want help managing pain, consult me in NASA. I mean, and because before that, everyone was just grossly undertreated because physicians were so scared. Like, they were like, what? You want me to give what? 4 Dilaudid every 2 hours? And yeah, and so we had to just reassure them a lot, put Narcan by the bedside and just tell them we take it one day at a time.
Interesting. Thank you all.
Thank you, Dr. Bowe, for the article link you added into the chat. I'll make sure to add that in the recap email as well for everyone. Jen, were there any other questions you wanted addressed before we move to the didactic portion?
I think that does it for now. Thank you very much.
Excellent. Thank you all for the comments and feedback, and thank you to both Jeremy and Jen for the excellent cases. So Dr. Husted, I'll just turn things over to you. I gave you some remote control. Let me know if there's any trouble pulling up your didactic, but the floor is yours.
Okay. All right, we'll see if this works. Okay. All right. Can everybody see a couple adorable kids?
Yes, we can.
Okay. All right. It's my son, Jeremy, different middle name, thankfully. I'm not that vain. My wife, he just turned 5 in April. So he was born during medical school, right? Well, actually right after I finished it. So he's 5 and just started kindergarten this past week. And then this is little Lavinia. She's 2.5 months old. So she's come to the Ridge once for a little Chick-fil-A picnic, but otherwise stays home. So last time we talked about it, kind of different domains of stigma, and then we're going to get into a little bit of a couple experiences I had. I'm by no means an expert on dealing with stigma. The reality is that if you treat substance use long enough, you're going to encounter a ton of stigma that gets in the way of it. I'm sure everybody here has stories. So trying to equip you a little bit in some things that I've done that I've felt like were helpful. Although, again, I'm by no means an expert on how to. I don't think anybody's quite ever figured out exactly how to deal with it perfectly, because if we did, then we'd share the secret sauce, the special recipe. You know, it's one of those things that it really does interfere with treatment, and you know, I'm certain that a lot of people have lost their lives simply because stigma prevented them from seeking treatment or pushed them away from treatment once they had already started it. So it's really unfortunate. So these are 2 cases I have that kind of represent stigma in substance use treatment and kind of how I approached it. So first case is, this is a 28-year-old female. And she was at Valley's crisis unit where I used to work for heroin detox and treatment in November of 2018. So this is a couple years ago when I first encountered this, but this is really what's kind of spurred me on to start doing advocacy work. So this lady had been using opioids for 5+ years. She was never on any consistent MAT, so lots of detoxes, a couple rehabs, not really getting any true gold standard treatment. Notably, she was involved in a local drug court secondary to legal issues, so obviously a big thing. The problem is she was symptomatically detoxed, which is what we would do at Valley because we weren't allowed to use buprenorphine, which is kind of interesting. We could refer people to bupe, but not inpatient in the crisis unit. But so she was symptomatically detoxed, and she was actually set to go to a 28-day program. So kind of like from the rule of law's view, kind of the best treatment you could get, what's believed to be the best treatment, detox, rehab. She was interested in starting naltrexone, so Vivitrol, which we actually typically offered for MAT from Valley. So we would detox people. One of the beauties of working in a detox place is you can actually put someone in the hospital for 7 or 10 days, get them completely off of opioids, and actually put them on naltrexone, oral naltrexone, and the Vivitrol shots. That's good if you can do it. However, her local drug court refused to allow her to even be on naltrexone. So not buprenorphine, not methadone, naltrexone we're talking here. So the drug court said, you can't even be on naltrexone. And what I heard was they wanted her to have cravings to use. They wanted her to be tempted and to prove that she was good enough to not relapse. And I wasn't actually treating this lady at the time. It was kind of interesting. I was a chief resident. I was off that week, and the other chief, who was also moonlighting, she was complaining about this to me. So I heard it, and my thoughts were, "What? You can't even do naltrexone." And I was flabbergasted, beyond frustrated when I heard this. So, my options were kind of at the time. So one was do nothing. Not accept, but accept. So accept, believe that, okay, they win. They're the drug courts. They're law. I can't change their minds. So they're not going to do naltrexone. All right, I can't convince them otherwise. So just kind of accept it, not accept. Get very upset and lash out. I was very tempted to do this. I was very frustrated by the situation, obviously. Patient that sounded like she really wanted to do things the right way, was going to go to long-term, and still, couldn't use a tool set. And then kind of the third thing I thought about was, okay, what if I try to advocate, to educate, try to figure out, okay, what's going on at this drug court? Why don't they want her to be on medicine? And so what it kind of led to at the time was this talk. So this is the exact slide from what I used, but trying to educate the judges and the caseworkers, the folks at the head of the drug court. They didn't really know anything about using medical treatment for opioid abuse. They certainly had a misunderstanding of what it was about. But for them, it was only people going to, cash and carry clinics in Pennsylvania and getting on Suboxone, or going to methadone clinics. So nobody really understood what was going on. So it was kind of neat as a way to educate them. But these are some things that I tried to focus on in this advocacy work, and I think can be helpful for you all if you're struggling with convincing people to be on medicine, or to allow someone to be on medicine. So addiction is a brain disease. So the idea, again, addiction is a chronic primary disease of brain reward, motivation, memory, and related circuitry. So this is from ASAM. So explaining, yes, addiction is a disease. It's not just bad habits, right? Inability to abstain, impairment in behavioral control, cravings, diminished recognition of problems, dysfunctional emotional response. So the hallmarks of what addiction is, it's not necessarily just drug use, it's all these other things that get wrapped into it. It's the behavioral controls, it's the cravings, it's acting like a different person. Explaining to them, okay, addiction is not a logical problem. It's not in the frontal cortex. It's not in the part of our brain that makes us people, right? Addiction is much deeper seated. It's basically the part of the brain that says you need to drink water or you need to get out of the cold. That's where addiction lives. That's why it's so difficult to treat. It's not simply a function of bad choices or not being clever enough to beat your addiction. It's much different than that. So explaining them, relapse and remission, obviously part of it. We like the remission, we don't like the relapse. People die from the disease of addiction, right? The idea of containing versus curing. Most things in medicine, can we truly cure, say, hypertension? Maybe in some very limited cases, right? If we have something we can go after. But a lot of times we're containing disease. Addiction's no different. It's very difficult to cure, if impossible, for that matter. And then explaining to them, okay, if we're providing care, if we're treating folks, what are our two main goals? And this always helps me kind of guide me when we're having these difficult talks and we're thinking about, do we do this? Do we do that? How do we approach the situation? Because these cases are often, a lot of different ways you can go about it. But the two main goals we have is keep our people alive, right? We can't treat them if they're dead. And if we are going to keep them alive, let's increase their quality of life. So let's give them back some of the things that addiction's taken from them. So they're alive, now give them a life worth living if you can. So they get their kids back, they go back to work, they're able to do things that they haven't done for a long time because of their addiction. So kind of explaining that to them. So, one of the things that I start posing with folks and I talk to medical students about is, when we're talking about addiction being a disease, these are some questions that I kind of pose to people, and feel free to use them if you find that they're helpful. So what I like to ask people is, what's the closest non-romantic connection two people can have? So normally I open it up but we don't have a ton of time. So what most people will argue is, parents and kids. Specifically, I would say mother and a child. So it's hard to get too much closer than that in terms of relationships than a parent and a child, mother and a child. So what I like to say is, what other disease or thing leads people to choose to continue to do or to use something over having their children? So the fact of the matter is that addiction can fracture the most sacred bond, you could say, between two human beings, that addiction can get in the way between a mother and a child. Think about that for a second. That's quite a bondage that people have, that you can drive a wedge between mother and child. If it was simply a bad choice, who in their right mind would ever choose something over their child? And that's the last thing I ask them, is who in their right mind could ever or would ever choose a substance over their child? So if it's just about logic, if it's just about choice, if it's just about being a bad habit, why or how could anybody in their right mind ever choose to use? If you have a judge saying to you, if you use, you're going to lose your kids forever. If you're sober, you get your kids back. Who in their right mind ever would choose to continue to use? It's just, it doesn't make sense in any level. All right. A little bit more into opioid use disorder, the ASAM guidelines that we have back from 2015, but something that I talk about. I won't read it all, but the idea is, again, this is a serious biopsychosocial spiritual illness. It's a fundamental neurological disorder. So, just like, say, epilepsy or Huntington's disease or something along those lines. So it's a fundamental neurological disorder of the brain. That's what addiction is. And explaining that to people, again, this isn't just me saying this. This isn't just WVU or ECHO. This is ASAM. These are national groups that are putting this kind of literature out there. If you look for it, you will find it. So if you're arguing for addiction being a disease worth treating, then you can find it. You can find this stuff out there to back you up. You don't have to go out on a limb and just put it forward as your own belief. So treatment options, when I talked about it with them, is kind of just, I try to keep it pretty simple. So one is do nothing or let people die. So this has been argued as treatment for opioid abuse, right? So we just kind of stand back. You know, you've had your 5 overdoses, your 5 doses of Narcan. Next time EMS shows up, we're just going to stand by and watch you die. People have argued that kind of stuff before. Obviously, from our side, that's unethical, right? So we would never do that. We always want to treat if we can. If you detox only, this doesn't work, okay? So for those familiar with ASAM guidelines, they don't even consider detox to be treatment, okay? So basically, detox by itself is malpractice. That's the simplest way to look at it, because what are you doing other than setting somebody up for relapse, potentially a fatal relapse? That's really all detox does by itself. Detox alone doesn't work, so don't do it, please. And I tell this to patients too, because I'll get some people that come in and they say, you know, I want to do it solo. I don't want to take medicines. I don't want to do this. I don't want to do that. And I'll say, I appreciate your enthusiasm. That's great, but I wouldn't recommend it. In fact, nobody would recommend it. Nobody in their right mind would recommend it. I don't want to do malpractice to you. I want to offer you options. You know, not necessarily Suboxone, but methadone or the Vivitrol, which again, this drug court wasn't even allowing us to use Vivitrol. So, you know, the fact that a court could prevent us from using the gold standard of treatment, just think about that. So detox plus 28 days. Sometimes works, but rarely works. So what a lot of people, if you poll people in judiciary system, they'd probably say, yeah, this is how we treat addiction. Detox, send them in 28 days or 90 days or 12 months or, you know, fill in the blank. It sometimes works, but again, you know, huge relapse rates. So a lot of people fail detox in 28 days because you're not addressing the underlying biological problems going on in somebody who's using opioids. Medication-assisted treatment, what we're doing here, or medications for opioid use disorder, whatever you want to call it. So it usually works. Not always, but usually. About 50% of people don't relapse. So we tend to talk about the bad cases, but guess what? A lot of people do really well with MAT. For people who actually do relapse, but you know, a lot of people still stay in treatment. So they might be struggling. They might be getting into trouble a little bit, but guess what? They're alive and they're in treatment. And that's something, because we're trying to keep people alive and we're trying to increase their quality of life. So MAT, you know, if you're a betting person, you wouldn't do detox. You might do 28 days, but you know, if you're making logical sense, you go for medications anytime that you have them available. So a little bit into MAT, this is what I told them. Back then, 2015, about 2.5 million people with opioid use disorder. Most of them didn't receive any kind of treatment, so 80%. It's safe and it's effective, especially what is MAT good for? Decreasing the frequency and quantity of opioid use and especially reducing the risk of overdose and death. So there's tons of studies. You can't really argue it. It's gold standard of treatment now, which was also part of the Surgeon General's report on opioids, by the way. So significant evidence to support it is effective treatment, remains highly underutilized and stigmatized. Again, what we're addressing here, some with the advocacy work. So a little bit more into MAT. It's a gold standard, as I said. Every professional addiction society recommends using medications. All these guys. 3 approved, they're all considered first line. We tend to focus on bup and Suboxone, but don't forget naltrexone. And we had already mentioned methadone tonight. Sometimes that can be a very good option, especially when pain is significant. But they're all approved. They're all considered first line. So one of the other things I do to try to bring home this idea of addiction being a disease and not just bad habits is, you know, let's pit it up against another disease. So again, feel free to use this if you find it helpful. If you're having to describe it to someone who's challenging, you know, addiction treatment. So we'll say opioid use disorder and just lung cancer. There's lots of different forms. We're not going to make it overly complicated, but just kind of general lung cancer. So if somebody struggles with opioids, they have to be exposed, right? You don't get exposed, you don't get addicted to them. Lung cancer, typically exposure to chemical, tobacco, but you know, sometimes other things can cause cancer. Months to years to develop dependency. So very rarely does somebody use one time and then suddenly, you know, they're an opioid addict for life. It's not really that. It takes a while to really progress into a true opioid use disorder. Same with lung cancer. So you don't suddenly get one cancer cell and now you have metastases everywhere. It takes a while. We don't treat it, it's fatal if you allow it to progress. So we think of overdoses a lot, but endocarditis was mentioned today. Hepatitis C, West Virginia leads the nation in it. Also, don't forget criminality. So if you're going out and using and buying, you have to put yourself in dangerous situations to get it typically. So a lot of people end up dead from drug deals gone bad and things like that. If you don't treat lung cancer, most people die from it. Either from the cancer itself or the treatment. Can you treat it with medicines? Absolutely. Same with lung cancer. If you'd compare them, what I would say is, detox is kind of like surgery to remove the primary, and then MAT is kind of like the chemotherapy, right? So very rarely do you just do surgery if somebody has mets all over the place. You have to actually do some additional work, right? So kind of, if we're trying to compare it, that's a good way to conceptualize it. So again, about 50% of people do pretty well with MAT. The reality is that even with our best treatments of lung cancer, about 50% of people die, or you could say 50% of people live. So it's not all that different from another disease. So opioid use, enormous amount of stigma, right? Sometimes the stigma of treating it is higher than the disease itself, which is, cancer treatment, lung cancer, there's not a lot of stigma with the disease or its treatment. However, for those who've been around long enough or know medical history, there used to be a lot of stigma when it came to treating cancer. So oncology was very much a fringe part of medicine. So people would just develop cancer, realize they had it, they wouldn't seek treatment, they would just kind of die with it. Things have obviously changed over time. We've gotten better with our treatment. It's less stigmatized. Most people, if they know they have cancer, are going to seek care, although there are some people that still won't even know. So, my hope with some of this, and I would say everybody's hope should be that, kind of look at ourselves as oncology in the early stages. So addiction treatment, we're working our way to becoming more mainstream, or if somebody has addiction, they want help, they can find it readily, they can find good help, they're not going to get stigmatized, they're just going to be treated. That's kind of the goal for everyone. All right, so what happened with all this drug court stuff? So they went to a 28-day program and they let them do the injectable naltrexone, and she completed the program, so that was great. I corrected some of their misconceptions, including one that they said, so some expert had told the judge that addiction goes away after 6 months, which I thought was great. Drug court and I, we left on good terms, so that was good. So no bickering, no fighting, so that was something. So that was kind of the first one. The second case, I'll briefly touch on it, but this happened about 6 months later. So another guy, similar circumstance, opioid use for years, started with pain pills. So like most of or a lot of our patients' stories. They got in trouble. 18 months in the drug court, same one as the first patient. They were on methadone off the streets for 3 years, long time. They got on bupe, and they were getting it by Dr. Bird. So they were getting it coat. They were in good control. The drug court, of course, did not want him to run on buprenorphine, even though he was stable on it, and they demanded inpatient detox and 28-day program. So, they were okay this time with him being on naltrexone, although, again, I would have preferred if they said, yeah, you can just keep him on bupe, if they would have listened a little harder, I guess. But they were more amenable to medical treatment plans. So they allowed us even to put him on an SNRI to help with pain and depression. And we got him off bupe, and we put him on naltrexone. And at last check, and this was a while ago, he was still sober. So it wasn't exactly ideal. I would have preferred him to stay on bupe, but at least this time around, they were okay with him being on Vivitrol. So that's so a little bit and kind of lessons I've learned, because this isn't my only interaction, fortunately or unfortunately, with criminal justice. So a little bit of lessons into it, because this tends to be one of the hardest groups to advocate with. So Usually, I don't know if we have any lawyers or people with criminal backgrounds, but typically you have to see very black and white to do your job right. So it's not a lot of gray, whereas addiction treatment is pretty much, well, it's a lot of gray. There are some judges and police officers that honestly believe that there's no utility to using bupe ever. Doesn't matter what you say, doesn't matter what things you show them, doesn't matter the statistics, doesn't matter if their own family members would die, I don't think. Some people, they won't go there ever. I've had a couple instances where I thought they were gonna like hold me in contempt of court or something for talking to them. And I think a lot of this is by negative anecdotal experiences. And, you know, consider too that a lot of people that end up in the criminal justice system, there's a lot of antisocial personality, so you have to be really careful. There are people that believe that those taking bupe are automatically impaired. So, you know, if you're taking the medicine, there's no way you can possibly do anything really. You know, you can't be a parent, you can't operate machinery, let alone be a doctor or nurse practitioner or something. Even though that some states are permitting it for physician help programs, that someone can actually be on bupe and be a physician, practicing physician, which is pretty neat. The training that people in criminal justice get is woefully inadequate. It's not provided by actual medical professionals, let alone addiction experts. So these are not people that actually have any sort of training in addiction treatment who are telling them things typically. If someone really doesn't believe in it, they're opposed to MAT, if you confront them, it rarely helps. So just keep that in mind. All right, a little bit in the stigma through advocacy. We've already kind of talked about it, but what I say is, you know, if you hear something, some misinformation, try to correct it gently if you can. So, you know, if you hear someone say, for instance, one of my favorites is Suboxone is worse than heroin. Okay. How many people has heroin killed last year? How many people died from Suboxone? You know, little things like that. You can correct it if you catch it. Try to stick with the evidence. So addiction is a disease. Treatment works. Okay, so if you start with that and kind of appeal to their own humanity, you know, you don't want to see people die any more than I do. This is what works. A detox doesn't work. You try to engage patients in their own advocacy. So people who have done well with addiction treatment, specifically with MAT, get them on your side. So having real life examples really does help when you're trying to do this stuff. Avoid the terms, we talk about this, but try not to say dirty or clean or this or that. Use alternatives. So for example, sober days. Try not to put stigmatizing images in presentations. This is something I was guilty of before, where I'd put pictures because I didn't know any better. But really, this just kind of fires people up, and it doesn't help treatment. It just gets people kind of emotional. And then one thing I say is, you know, you try to be assertive in advocacy. So it's very hard to be kind of meek when you approach this stuff. So if you it's difficult if you're a fairly introverted person, which I actually am, to assert yourself, but it's something you need to do when you're advocating for patients. And then, you know, just always be prepared to be an advocate, whether it's in big situations like talking to judges or just talking with the patient, because there is this idea of kind of personal stigma. So patients don't like themselves, what they become, and sometimes they need some help just to kind of learn to love themselves or accept what's going on with them. Real quick, this quote on silence I like. All too often when we see injustices, both great and small, we think that's terrible, but we do nothing. We say nothing. We let other people fight their own battles. We remain silent because silence is easier. Qui tacet consentare. I'm not a Latin expert, so Bedouin is Latin for silence gives consent. So when we say nothing, when we do nothing, we are consenting to these trespasses against us. So you can't be silent and also advocate, right? So you're going to have to speak up at some point, even if it is uncomfortable. So just briefly in summary, substance use extremely common, stigma, as is the stigma that we deal with. Substance use is a brain disease, not just bad choices. There are different domains of stigma, including the personal, kind of medical, criminal justice, and societal. Stigma interferes with treatment that it would otherwise be effective. As healthcare people, one of our responsibilities is to be advocates, whether we want to or not. Use your own advocacy to combat stigma and avoid letting societal or any stigma really prevent you from providing excellent care to people who struggle with the disease of addiction. So I know that it got us right to the end. I appreciate everybody's attention. I hope that this was helpful. Feel free to reach out to me. I'll be on the ECHO calls from here forward. I just appreciate everybody's attention. So.
That was excellent. Thank you so much, Dr. Husted. And I love the family pictures you incorporated. That was great. So I know we are at the end of the session time, but I wanted to ask if there were any questions out there that anyone had for Dr. Husted.
I can remain on a few extra minutes if people need to get off for whatever reason.
Yeah, I had just like a comment. So here in Charleston, sometimes the police actually give patients DUIs if they see them have a prescription of Suboxone in the car.
Oh, that's nice.
What? Look here. So,
Right.
how do I advocate for that? Like, because if they're hearing from their drug courts that Suboxone is just like heroin, no wonder they're doing that.
Yeah.
We've had at least 3 patients now say that. And first I was like,
Yeah.
the third
Once
one.
you hear it like 2 or 3 times, you know it's a thing, right? What I will say is the Supreme Court, the head of the Supreme Court of West Virginia is an advocate of treatment. From a national standpoint, drug courts aren't supposed to do this. And from a statewide standpoint. So these are like rogue drug courts that are doing this. The training is woefully inadequate. I had a PCSS training, Suboxone for people a couple weeks ago, and one of the girls in there, her friend had just graduated criminal justice, and they were still being taught the same nonsense about BUP. And this was like a month ago they were trained. So there's so much misinformation out there. So you try to correct it. I would write, to me, if it was my person, I would write a letter. I would just say, this person's not altered. They're more altered being on, say, oxycodone. Are you pulling over every grandma that's on oxycodone or every physician that's on oxycodone? Or, you didn't do anything about it for 20 years. Suddenly you want to give everybody on BUP a thing. So I don't know. It's difficult. It's a struggle. And, I firmly believe the stigma is just what's killing people, honestly. You reduce some of that and you just start talk to people about it. And I start micro level, patient to patient. You move up to more like societal things. So your institution, wherever you're working. And then, these opportunities arise where you can talk to people and things. A lot of it's been put on hold with COVID, but beforehand it was going pretty well. So.
And we are, just so you know, Adina, we are going to be starting basically an ECHO for judges soon. So we're going to try and do some education and really collaboration, and maybe they will have some ideas for us about how to advocate for our patients on MAT. I'm hoping that they do. So that's something we're launching in September.
Thank you, Laura, for mentioning that. That's very relevant. Any other questions, comments, thoughts before we part ways?
I'm just, Mithra, I'm just looking, there's some things in the chat that were shared. Is there any way you can include those in a follow-up email?
Absolutely. I'll attach both the links that Dr. Bowe and Morrison added in there into the recap email. So
yeah, thank you guys.
All right, well, thank you all so much. Just a couple housekeeping announcements as usual. Our next session will be on September 14th, and Katie Chasson-Downs will be providing the didactic on therapy approaches in SUD. So keep an eye out for that reminder. Just another quick announcement is we are launching a memory health echo that's focused around Alzheimer's. So if anyone is interested in joining in on that, just shoot me an email and I can send over the registration link for that. I want to give a big shout out to Jeremy Sagan, Jen Boyd, and Dr. Husted for the cases and the didactic today. And thank you all so much for joining. I look forward to my Mondays because of you guys, so I really appreciate it. I'll see you all next time.
Take care, everybody.